Every imaging technology we have built, X-ray, CT, MRI, ultrasound, works by sending energy into the body from outside and measuring what comes back. Nuclear medicine does the opposite. We put the radiation inside the patient. The patient becomes the source. And what we can learn from that reversal is unlike anything conventional imaging can show us. The distinction that matters is this: anatomical imaging shows structure, nuclear medicine shows function. A CT scan tells you the shape of a tumor. A PET scan tells you whether that tumor is metabolically active, whether it is consuming glucose at an accelerated rate. This difference changes clinical decisions entirely. Positron emission tomography begins with antimatter. A radiotracer that emits positrons, the antimatter counterpart of the electron, is injected into the patient. Each positron travels 1 to 2 millimeters through tissue before encountering an electron. When they meet, both particles annihilate completely. Their mass converts to energy in the form of 2 gamma-ray photons. These photons fly in exactly opposite directions, 180 degrees apart. The PET scanner is a ring of detectors surrounding the patient. When 2 detectors on opposite sides fire within nanoseconds of each other, the scanner knows an annihilation event occurred on the line connecting them. Reconstruct thousands of these coincidence lines, and you get a 3-dimensional map of tracer distribution, localized to within 2 millimeters, using antimatter.
Single photon emission computed tomography works differently. Rather than detecting coincident pairs, SPECT detects individual gamma rays emitted directly by the radiotracer. The dominant agent is technetium-99m. It has a 6-hour half-life. It emits a single 140 kiloelectron-volt gamma ray, energetic enough to escape the body, low enough to be efficiently detected. A gamma camera, a large flat detector, rotates around the patient, recording projections at angles separated by a few degrees. The mathematics of reconstruction are identical to CT, the radon transform, filtered back projection, iterative algorithms. The difference is the source. In CT, X-rays are generated externally. In SPECT, the gamma rays come from inside. Technetium-99m can be chemically attached to almost any biologically active molecule. This versatility makes SPECT the most widely performed nuclear medicine procedure in the world. The radiotracer concept is elegant in its simplicity. Take a molecule the body uses naturally, attach a radioactive atom to it, inject it. The molecule carries the radioactive label to wherever it would normally go. Fluorodeoxyglucose, FDG, is glucose labeled with fluorine-18. Cancer cells are metabolically hyperactive. They consume glucose at rates far exceeding normal tissue. When FDG is administered, it accumulates disproportionately in tumor cells. The PET scanner sees them as regions of intense signal, not because of how they look, but because of what they are doing. Fluorine-18 has a half-life of 110 minutes. By the time imaging is complete, the radioactivity has largely decayed.
The same logic that makes radiotracers work for imaging can be turned toward treatment. Instead of a tracer that emits gamma rays for detection, attach a therapeutic radionuclide, one that emits radiation that deposits energy locally and destroys cells. Lutetium-177 DOTATATE is the clearest example of this approach reaching clinical practice. The DOTATATE molecule binds specifically to somatostatin receptors. Neuroendocrine tumor cells express these receptors in abundance. Mammal tissue does not. The Lutetium-177 emits beta particles that travel a few millimeters through tissue, enough to irradiate the tumor cell and its immediate neighbors, while leaving more distant healthy tissue largely unaffected. This is systemic radiation therapy. It reaches every tumor deposit in the body simultaneously, regardless of how many they are or where they sit. The precision of targeted radionuclide therapy can be taken further. Alpha particles deposit all their energy within 40 to 90 micrometers, 2 to 3 cell diameters. The damage is catastrophic for the cell receiving it, but it extends no further. This extraordinary range precision allows us to treat scenarios that beta emitters cannot. Tumor cells scattered individually among healthy cells, where broader irradiation would cause unacceptable collateral damage. Lead-212 is one of the alpha emitters currently in clinical development. It undergoes a 2-stage decay, first to bismuth-212, which then emits the alpha particle. This sequential process extends the therapeutic window and allows the carrier molecule time to bind before the lethal radiation is released. The physics is demanding, the dosimetry is complex, but for patients with disseminated cancer, where conventional approaches have failed, targeted alpha therapy represents a genuinely new category of treatment. That is why nuclear medicine exists, not to see the body, to change what happens inside it.